Hello. Today we are going to discuss the cause and treatment of obesity from the perspective of our practice, where we treat literally thousands of obese people, and we see common trends and certain patterns that identify for us why people become heavy and what the most effective strategies are to treat these patients. I am Dr. Robert Sivers. I'm a pediatric surgeon. I run a multidisciplinary obesity management program suited to community practice. We have practice locations in Jacksonville as well as in West Palm Beach. My primary focus is on the management of childhood, adolescent, and adult obesity using a surgical program. The objective of today's talk are to define, first of all, what makes us fat, to understand the facts related to the pathophysiology of obesity. We then want to identify who's vulnerable, which people may become fat, and we want to recognize the context of that vulnerable population. Thirdly, we'll examine why now. We'll look at the epidemiology of the obesity epidemic and define the causes of why our generations have become heavier and heavier. Once we have a consensus on the cause of a problem, we can then come to consensus on therapy. I can tell you one thing about obesity management right now. Everybody's an expert. Whether you're fat, whether you're a healthcare worker or not, everybody's an expert, but nobody's really effectively managing the problem. So we'll talk about how we fix fat, what therapeutic strategies we use in our practice, and I'll also give you some preventative strategies and strategies you can use in your local environment. The most important thing that we have to start with is recognizing that a child is fat. And as bizarre as that is, just by looking at a person you can tell whether they're heavy or not. We make a lot of excuses and do a lot of defensive work in terms of defending the current status of our patients and of ourselves. We have to overcome this, acknowledge the problem before we can deal with it. On June the 16th, 2013, the New York Times reported the following. The American Medical Association has officially recognized obesity as a disease, a move that could induce physicians to pay more attention to the condition and spur more insurers to pay for treatments. On June 16, 2013, obesity became the commonest serious chronic disease in America. Obesity rates are running rampant. Everybody has been saying, oh, it'll level off, there's a certain population that'll become this way, oh, it's genetic, oh, it's absolutely not true. As you can see from this graph, from the early 1960s to today, obesity rates amongst our kids have been growing in meteoric fashion. This is an exponential growth, and it's not stopping. By next year, 2015, we expect 1/4 of our adolescents, 12 to 19 years of age, to be overweight, and nearly as many in the 6 to 11-year category to be the same. Literally half of our patients, half of our population in the U.S. will be fat by 2030. Those are astronomical numbers. When we measure obesity in adults, we commonly use the adult BMI table. This is effective for adults. However, what we've got to understand is that pound for pound, children are significantly worse off. So a child of 14 with a BMI of 20, who may actually be normal by BMI, is actually severely overweight when you extrapolate back to adult BMI chart. So while for older kids this may be appropriate, it certainly isn't appropriate for our younger children. It is far better to use the CDC tables for children that really give the truth. We become so accustomed to seeing large kids that a skinny normal child is actually considered to be underweight, and an overweight or obese child is now considered to be normal just by our visualization. But this is a belief. This is not a fact. And therefore, if we under-recognize it, we under-treat the problem. So in reality, the best way to look at fat is to look at the normal tables. And if a child falls above the 97th percentile, irrespective of their age, they've got a real problem, not just in terms of their weight, but in terms of the comorbid diseases that are already beginning, even if that child is still very young. If we plot these graphs, we can also use these graphs to effectively show parents and children where they fall. And if they fall outside the norm, outside that bell curve, that's a concern. And that's true also for skinny kids. they fall below the third percentile, that's also something we can address. You can go to our website, obesityresolve.com. It is calculated to determine what the BMI is. All you have to do is plug in the height and the weight of the child and their age, and it'll give you their BMI, and you can plot it on these graphs. So what makes us fat? Let's examine the pathophysiology of obesity. This is a busy slide, but let me work you through it. The way the human brain works, genetically, we have been set up over thousands of years to have two centers that govern our nutrition and our thirst. One is called the hunger center, the other is called the thirst center. And these are regulated in very, very tight homeostatic fashion. In other words, there's a feedback mechanism that when your hunger gets triggered and you satisfy your hunger, it shuts off your eating and drinking so that harm will not come. In fact, if you eat according to your hunger center and drink according to your thirst center, bad things typically do not happen. The way that these centers work is very similar to the gas tank in your car. You're driving along, la-di-da-di-da, minding your own business, and you're using up energy. Well, what happens is as your gas tank gets empty, it gets to a critically low value, or your oil tank or whatever it may be gets to a critically low value, and the little red light on your dashboard goes off, and your car tells you, whoa, you're getting low on gas. So you panic a little bit, you pay attention to it, you focus on it, you pull into a gas station, and you pump gas. As you hold that gas handle down, as soon as your tank is full, the tank shuts off the pump. It stops you from pumping too much gas. And therefore, the tank will tell you when it's empty, but it'll also tell you when it's full. And typically what we'll do is we'll fill the tank when it needs to be filled. So if you run to that red light and you fill it to the top, you're probably filling your car according to your needs. And under those circumstances, the typical human being needs to eat food, needs to satisfy their hunger center. In other words, the hunger center gets activated somewhere between 1 and 3 times a day. And these are very, very powerful somatic signals. So if you think about a healthy dog, a dog typically has a very, very structured way of eating. The vet will tell us how much food to give that dog, and most people will feed the dog once or twice a day, same place, same time, same amount of food. And during those meals, the dog gets everything it needs in a 24-hour period to satisfy its nutritional needs. Human beings are not that different. So if we get into a regular pattern of utilization and of feeding, we should be feeding once, twice, or maybe 3 times a day. And that's why breakfast, lunch, and dinner exist. But it's absolutely fine to skip meals from time to time. If you're not hungry, it's okay not to eat. This whole concept that breakfast is the most important meal of the day, that's ludicrous. For some people it is, but for a lot of us it just isn't. So the way that the hunger center works, there are 2 aspects to it. The first aspect is that hunger center's job is to provide adequate nutrients for growth, repair, and stabilization of the body's needs. These things are essential to the human body. In other words, they have to be consumed. They cannot be produced within. And we call these elements essential nutrients. About 20% of the average daily intake of a human being are essential, and every human being needs to eat these. These include certain amino acids in the form of protein. Some of them can be made internally, but a lot of them need to be eaten because you cannot produce them. Certain fatty acids. I'm not talking about pork fat. I'm talking about essential fatty acids and fatty elements that are required for building the body. Certainly we need fiber, we need vitamins, we need micronutrients, we need electrolytes, and these things cannot be produced. So when these levels get low, our hunger center gets activated, we're hungry, we find these things, we consume them, and when we've restored or replenished our stores, our hunger goes away for a protracted period of time. The hunger center tightly regulates quantity and frequency by a genetic homeostasis feedback, and the hunger center will not let you overeat. So therefore, I've made the statement, it is impossible to get fat from eating food. Food that has hunger value will not allow you to become fat because of that stopping capability. And I'll prove this to you in several ways. The other aspect of the hunger center is that hunger also serves our energy needs. In a normal person, we have a small amount of energy stored in our fat stores between meals. But as we utilize these fat stores and the storage of sugar or glycogen in our liver, as those get to a low point, they may also trigger the hunger center. What we need to satisfy this need are some form of calorie. Calories come in the form of protein, carbohydrates, and fat. Now, all three of these, from a calorie perspective, are interchangeable. In other words, you can make fat into sugar, you can keep the fat as the fat. You can make sugar into fat, or you can store it as sugar. Protein can be made both into fat and into sugar. So these are interchangeable, and it doesn't matter which of these you take in, they are all forms of calories. And the body will store them as a small amount of sugar in the fat, and then the majority of the calories that you consume, even in a skinny, healthy person, will be stored in the fat stores. That's the way the body works. So as you eat a meal, you take in these calories, the body distributes a small amount to the liver, and the rest it distributes to the fat stores for utilization between meals. A normal person needs to take up to 80% of their entire meal in the form of calories. However, an obese person already carries those in their fat cells. So therefore, an obese person should not be eating for the energy value. In other words, the less energy-containing foods an obese person eats, the more they lose weight. Up to 80% of the intake of a normal person is in the form of calories. And when you eat the calories in terms of protein and fat, there is also a stopping point. So when you've eaten a certain amount of calories to satisfy your energy needs, and these are from a protein or a fat source, the human body will shut you down in a homeostatic, controlled fashion. However, and here's the problem, there is no genetic control over the consumption of carbohydrates, and I'll explain why in the next slide. So the pancreas and the liver tightly control and triage what we eat. So no matter what we eat for a meal, the liver triages those nutrients to certain stores or remanufactures them and sends them to where they need it. It stores a small amount of the calories that we've eaten as glycogen in the liver, and then the majority of the energy that we've eaten gets converted to fat by the liver and gets stored as fat. The insulin-glycogen ratio from our pancreas governs whether fat is being stored or fat is being utilized. So therefore, right after a meal, we're living off glucose, we're in a state of glycosis, but as the glucose goes away, we convert to breaking fat down, and between meals, we typically run off a system of ketosis, and this is a healthy ebb and flow between the liver and the fat stores. So we're liver dominant when food goes in, and then fat store dominant between meals. That's the way the body works. A simplistic way to understand this is to look at an egg. It's so ridiculous to see people that, oh, I've got to only eat egg whites, the yolk is bad for me. That is a horrendous belief that has no factual support. The egg yolk contains all the vital, essential nutrients for the chicken. And when we eat the egg yolk, it is a wonderful way to satisfy our essential protein, fat, fiber, vitamin, micronutrient, and electrolyte needs. The egg white is pure albumin. Small amount has value as protein, but most of it is just used as calories. So if you're that person that's just eating egg whites because it's healthy, basically all you're doing is taking in energy, and you're depriving yourself of the nutrients that are contained in the yolk. An egg is perfectly healthy, and we have to change our belief that it's not. So the healthy human body alternates between glycosis, burning of sugar right after a meal, and ketosis between meals, where you're using the energy that's been stored in your fat cells. Now, if we cannot become fat by eating food, what does make us fat? Well, in order to understand this, we have to look at brain physiology. The brain also has an essential center called the endorphin center. And the endorphin center is used to relax the brain between periods of focus. The human brain can focus for around 20 to 30 minutes at any given time, and then it needs a break. And it's going to take a break. The mechanism that the brain uses is to use certain actions, certain substances that activate the endorphin chemicals that give us a sense of well-being, of relaxation, good feeling. And this gives us pleasure, and just that simple thing relaxes the brain, resets the brain so it can refocus for the next 15, 20, 30 minutes. In fact, as you look at this talk, there will be certain slides that I call my break slides, and they're designed to give us those breaks. So most human beings, over time, develop a diversity of endorphin activating mechanisms that include pleasurable effort-based actions. So if you do something that gives you pleasure, it activates the endorphin center. Or we may consume certain pleasurable substances, certain substances that primarily activate the endorphin center. Endorphin releasing mechanisms, however, are unregulated by genetic feedback homeostasis. So therefore, any endorphin releasing mechanism may become dominant and excessively used if we buy into that form of pleasure on a regular basis. When you use any of these things, whether they're healthy or unhealthy, when you use any of these methods in a dominant and excessive way over time, it usually results in harm. And when we ignore the harm that it's causing us, and the behavior pattern continues, we lose control of the relationship with that substance or with that action, and that becomes an addiction. When we tolerate harm or ignore harm and the behavior pattern continues, we've lost control of the relationship. We have an addiction. So, what makes us fat? Well, it's very simple. Food that has nutritional value is eaten primarily in response to the brain's hunger center or thirst center. However, there is something, a substance that we eat, that actually doesn't activate the hunger center from a nutritional perspective. Yes, it does have some calories, but it's not necessary. But this particular substance is an extremely powerful endorphin center activating substance, and that's called carbohydrates, sugars and starches. And it doesn't matter how these sugars and starches get into your body. It doesn't matter if it's ice cream, chocolates, chips, pasta, bread, rice, cereal, Coke, orange juice. Sugar is sugar by the time it enters your bloodstream, and it is a potent endorphin-releasing substance. And the more of it we eat, the better we feel. So we're continuously eating way more than our bodies ordinarily would allow us to eat, because we're able to override the regular control of the thirst and hunger center because we're eating not for thirst and hunger, we're eating for pleasure. Let me give you some examples, okay? If you're really thirsty, your thirst center light goes off, ping. You're thirsty, you want hydration. Well, we try not to drink our calories. So if you're really thirsty and I put a case of water in front of you, how much water can you drink? In my own personal life, I can drink 1 or 2 bottles of water, maybe 3 at a push. But as soon as my thirst is quenched, I stop drinking. I can be halfway through a bottle of water, go, boom, I'm done. I don't need any more. My thirst center has been satisfied, my thirst has been quenched, and my thirst mechanism shuts down, and I cannot drink more water. So the other 22, 23 bottles just lie there, even though they're free. However, if my thirst center becomes activated, and I'm really thirsty, and you put a case of beer in front of me, and I've done this experiment a few times in college, I can drink the whole case. I can sit down and drink the whole case of beer. Can't drink the water. By volume, they're the same. So why is it that I can't drink the water, but I can drink the beer? It's very simple. The alcohol is not being drunken in response to my thirst center. It's being consumed in response to my endorphin center. The more I drink, the more pleasurable it is. And if I don't regulate it by conscious decision, I can keep drinking until I run out of beer, until I pass out, or until I make a conscious decision to stop drinking. I don't have to decide when I'm going to stop drinking water. My body decides that. But when it's beer, I have to stop drinking after 2 or 3 beers, otherwise I'm going to get drunk. And if I do that repetitively, hell, you might as well call me Lindsay Lohan. Think about this. If you're really hungry, your hunger center goes off, and I love cow. I love to eat cow. So you put a big 64-ounce block of ribeye steak in front of me. Oh, I'm salivating. I start eating. I could probably eat 18, 20, 22 ounces of ribeye steak. And then I'm so full I'm about to burst. My hunger center has been satisfied. It shuts me down. And as much as I love steak, I can't eat another morsel of that ribeye, despite the fact that I love it. Well, what's in the ribeye? It's a lot of protein, a lot of fat. Two things that are satisfying my nutrition center, both from a protein and a fat nutrient perspective, as well as from a calorie perspective. But as soon as I'm full of ribeye, boom, I'm done. I can't eat any more. And I push my plate away. You then put a big tub of Haagen-Dazs in front of me. It's gone. And guess what? I'm also looking for yours. In other words, I can supersede or overwhelm my hunger center when I'm consuming something that gives me pleasure. Because let's face it, the Haagen-Dazs doesn't have a lot of nutrients in it. It's primarily being eaten in response to the endorphin center. And I can eat a huge, huge amount of ice cream. And in fact, I'll eat ice cream until it's all gone. Or I have to make a conscious decision to only eat a small amount. But because I'm a fat guy, I eat in a dominant and excessive way, and I continue to find ways to convince myself I can continue to do it. Therein lies the problem. If you think about a smoker, what a fat person then does, if carbohydrates become your dominant source of endorphin release, your dominant source of emotion management, we become like smokers. Smoking is just the same. Nicotine is a very, very powerful endorphin-releasing agent. And remember, the brain needs to relax 20 to 30 times a day, every 20 to 30 minutes. So therefore, what a smoker will do is they'll surround themselves with cigarettes. They'll always have the cigarettes in their pocket, in their purse. They'll always have easy access to them. And every 20 to 30 minutes, they're continuously thinking or desiring a cigarette. They're finding ways to go outside. They put their busy lives on hold in order to go outside for 2 to 5 minutes to have those few puffs on a cigarette. In exactly the same way, an obese person surrounds themselves with easy access to little bits and little bites and little snacks here and there, and we have easy access to them. They're in the drawer at work. They're in the fridge in the pantry at home. They're on the way home at McDonald's. They're in a variety of different ways, and we set our lives up to give ourselves easy access to our drug of choice on a regular basis. So we surround ourselves with that drug irrespective of what it is. Now, you may go the whole day without eating anything, but at night when you come home and you're relaxing, that's when you do it. There are plenty of alcoholics out there who don't drink during the day. They're called functional alcoholics, the businessmen that are very successful, but that first scotch is poured as soon as they get home, and they keep drinking until they fall asleep at night. There's a variety of different ways in which this works. Some people drink throughout the day. Some people drink alcohol only at night. They're still alcoholics. They still have an addiction because harm is happening to them, and they're ignoring the harm to continue the behavior. There's nobody in the world that doesn't know that Haagen-Dazs ice cream is probably not a good thing to eat. Yeah, it's pleasurable, but it's probably not that good for you. And especially for an obese, diabetic, hypertensive, sleep apnea person, probably not a good idea. And yet we distort the reality of the harm, and we've got these wonderful, sophisticated ways to rationalize and justify and validate to ourselves that right now it's okay to eat the ice cream because of this and that reason, and we ignore the harm. Guess what? Whether it's cigarettes, whether it's alcohol, whether it's crack cocaine, whether it's carbohydrates, that's an addiction. Now, we know that the human body requires nutrition from a hunger perspective once, twice, or maybe 3 times a day. But the brain needs to relax 20 to 30 times a day. So if you look at a healthy person will typically eat, when they're hungry, a couple of times a day. The fat person will put calories into their face 15, 20, 30 times a day. So those are called snacks. And a snack is a calorie-containing substance that we eat in response to our emotional needs throughout the day to activate our endorphin center. It is never eaten in response to nutrition. A bridge, however, is a snack that doesn't contain calories. A bridge is something we use in therapy that gets our people across that moment where they really need, I need a snack. But a snack does harm, a bridge does no harm, yet it still satisfies the endorphin need. So having access to a glass of water that you can sip on, having something that you can eat or drink that doesn't contain calories. For example, a piece of chewing gum. So when you give up your smoking, you can have that gum. Think about a dog. A healthy dog is one that gets fed once or twice a day. The fat dog is that dog that's always in the kitchen and hanging around and standing up on its hind legs and begging for food, and a little bit for you and a little bit for me. It doesn't matter what it is, because it's getting its emotional needs met by little scraps and little snacks from the table, whereas the healthy dog is eating for the nutritional value, and that dog is chasing the mailman, playing with its toys for its endorphin release. Sugar is a drug, not a food. That is such a critical concept. Do not put sugars and starches on your plate. They're drugs. Some of us can consume a little bit of alcohol from time to time because we're not alcoholics. Some of us can smoke a cigar from time to time because we're not smokers. But there is a bit of a slippery slope right there. Some of us can eat carbohydrates because we eat them from time to time and we have not done ourselves harm. Those are the skinny people. However, for most of us, sugar is a drug, not a food. Yes, glucose is essential to life. We have to have sugar within our bodies. Our blood sugar is very, very tightly controlled by the insulin-glucagon clamp, which is the relationship between the liver and the pancreas. However, here's the crucial point. Sugar can be produced internally from any other of the calorie-containing substances by the liver. So therefore, while sugar is essential in our bloodstream, it does not need to be consumed, since it is produced internally through a process of gluconeogenesis. Let's look at the egg, for example. The egg is nature's Rubik's Cube. Okay? Everything you need to make a chicken is contained in an egg. You twist the chemicals in the egg this way and that way, and suddenly you've got a chicken. Nature's Rubik's Cube. So therefore, what is in the egg has to be essential for life. That's what forms the chicken. At the same time, if a certain substance is not in an egg, it therefore is not necessary or essential for life. So, an egg contains a lot of protein, a moderate amount of fat, a lot of cholesterol, a lot of vitamins and nutrients, but there are no carbohydrates in an egg. So therefore, carbohydrates are not essential to convert an egg to a chicken. And the same is true for us. Yes, absolutely, for primates, there was an historical advantage to being able to consume carbohydrates when they were in very limited amounts, both from a pleasure perspective and a survival perspective. But this historical survival advantage is now passé. It has become redundant, and by exploiting that historical survival advantage, it has done us a great deal of harm. Okay? In the days of old, sugar was a very, very rare commodity. Now it is everywhere. And that has become harmful because sugar is a very powerful endorphin activator. It has the same endorphin releasing capacity as nicotine, as alcohol, as crack cocaine, as heroin. Look at the picture of these kids. All of them are doing drugs. Because the more they consume, the higher they get, the more they desire, and they're not shutting it down. So that excessive carbohydrate consumption, both in terms of frequency and quantity, results in excess calorie consumption beyond what the body's regulation does from the hunger center, and this results in obesity. When we are using carbohydrates as the primary source of our endorphin management, remember that carbohydrates do not contain a huge amount of nutrients. So the average obese person, when they are carbohydrate driven, 70 to 90% of their individual total calorie consumption comes from the source of sugars. So therefore, if you're eating so much sugar and starch, you're not eating what your body really needs. You're not giving it the essential nutrients it needs in terms of protein and fats. And the result is that obesity is also tightly correlated with malnutrition because we're not getting in enough of the vital nutrients. And here's the myth that, again, this belief that gets perseverated throughout our community. The myth of good carbohydrates and bad carbohydrates. We typically judge a food in society by what the carbohydrates are attached to. So, for example, most people say to you, oh, a cookie's bad for you, don't eat the chocolate chip cookie. But this apple is really good for you because it's got all these nutrients in it. Well, look at the sugar content of a chocolate chip cookie and look at the sugar content of an apple. They're identical. Yes, there are a few nutrients in the apple, but the nutrient value for an obese person is way superseded by the harm that the sugar does. Because it doesn't matter what the vehicle is, those carbohydrates are toxic and harmful to our body. Also, what we've got to understand is an apple of today is not an apple of yesterday. And that's a crucial point. The apple that I grew up on was this tiny little sour thing that contained very little sugar and a high, intense concentration of nutrients. Today, the apples are huge, they last forever, and we've genetically engineered them to contain a massive quantity of sugar. So in fact, we are designing drugs for our kids and calling them healthy. So, I've said this once and I'm going to say it again. It is impossible to be fat and healthy because of the way in which we consume these carbohydrates. The current hypothesis in the world out there is that as you gain weight, you gain comorbidities. In other words, obesity causes harm to the human body. Obesity results in type 2 diabetes, obesity results in heart disease, obesity results in hypertension, results in sleep apnea, results in gallstones, results in acid reflux, results in liver disease. So obesity is the cause of all of these diseases. And when you lose weight, the weight loss causes these obesity-related comorbidities to go away. That's the current conceptual understanding. And therefore, the focus has been on the treatment of obesity. If you lose weight, these things get better, and that's been the primary treatment paradigm of the obesity management world out there. And how do you lose weight? You restrict calories. So if you reduce your global calories by some magical scientific formula, as the obesity goes away, and it does, if you restrict your calories, irrespective by which plan, you will lose weight. And your comorbidities go away by this formula. But guess what? That is totally and absolutely wrong. And we've got to understand the concept called the obesity paradox. Absolutely. Early on, by losing weight, there's a transient reduction in the severity of comorbidities. What we're really doing is slowing the progression of the comorbidities by not feeding us the drug that causes them. However, we don't cure those comorbidities. They don't go away. You might stabilize your diabetes, but there's still a requirement for ongoing medication to treat those comorbidities. Because what we're doing is we're reducing calories. We're treating the disease called obesity by reducing our calories, but we're not treating all the other comorbidities because our conceptual understanding is just dead wrong. Here's the truth. Obesity is not the cause of all of these problems. Obesity is the consequence of chronic excessive carbohydrate consumption. In other words, the drug called carbohydrates causes all of the comorbidities, and amongst the list of comorbidities is something called obesity. For example, nicotine causes heart disease, it causes emphysema, it causes lung disease. It's not the emphysema that causes the heart disease. It's the nicotine. Alcohol causes liver disease. It's the drug that causes the liver disease. Okay? Nobody in their right mind is going to smoke 3 cigarettes and go for a 5-mile run to breathe the nicotine out of their lungs and say, oh, look, I'm cured. But that's exactly what we do with carbohydrates. We'll eat some ice cream and then go to the gym and try to run it off. Well, that's ludicrous. You may burn the calories off, but those carbohydrates are harmful as they go into your bloodstream. So here's the ridiculous part. When we treat obesity, we slow the progression of one disease, but we don't treat the entire process. Okay? What we have to do is we have to treat carbohydrate addiction, and in doing so, we cure many illnesses. I'll give you a more simplistic example to understand this. Okay? A patient comes to see you and they've got emphysema. They need treatment of the emphysema. So what caused the emphysema? The emphysema was caused by smoking. So yeah, you've got to treat the emphysema with medication, but you've also got to help the patient to quit smoking. And when they quit smoking, their emphysema will improve, but they may require ongoing medications to continue to treat the harm that has already occurred. We don't just treat the emphysema and ignore the smoking. We also don't just treat the smoking and ignore the emphysema. We have to treat both. In the same way, yes, we have to treat the obesity, the diabetes, the hypertension, but if we don't help the patient to address their carbohydrate addiction, all we're doing is slowing down the progression of the disease. So a fat person goes on a diet, they lose a bit of weight, and right away some emotional event happens, boom, they're eating again, and they're going back to those carbohydrates because they haven't replaced them in their lives. So there's this fluctuation of weight. And every fat person knows they'll go on a diet, lose a little bit of weight, and then right away the weight comes back and it brings some friends. It's like a bank loan and you have to pay it back with interest. If you treat the carbohydrate addiction and you use addiction principles, very similar to smoking or nicotine principles, and you help the person to stay away from carbohydrates, not only do they lose a huge amount of weight because they're not consuming those excessive calories, they're now eating for their hunger center, not their endorphin center, their diabetes, their hyperlipidemia, their hypertension, their sleep apnea, all of those diseases go away as well. So treating carbohydrate addiction is curative. Treating obesity is palliative. And that's such an essential concept to understand, is that obesity is a consequence of chronic excessive carbohydrate consumption, not a cause of all of these diseases. You don't believe me? Well, let me explain to you how carbohydrates are toxic at consumption. Let's take two common problems associated with obesity. Type 2 diabetes and hypertension. How do they work? Well, it's simple. Type 2 diabetes is not a disease of the pancreas. In type 2 diabetics, the pancreas is normal. What happens is we consume chronic excessive amounts of sugar over a chronic period of time. And it doesn't matter how the sugar enters our mouth. It could be ice cream, chocolate, chips, pasta, bread, rice, Coke, cereal. By the time it enters our bloodstream, that is glucose, galactose, and fructose. Those are the three primary sugars. And it elevates our blood sugar. In response to an elevated blood sugar, the pancreas releases insulin. Insulin controls sugar by forcing the sugar into the liver, into the fat cells. It blocks fat breakdown and helps to clear the bloodstream of sugar. However, if you on a regular basis are consuming large quantities of carbohydrate, or you're consuming carbohydrates on a regular basis, you supersede the maximum insulin producing capacity of your pancreas. Excuse me. And when you supersede the maximum insulin producing capacity of the pancreas, and your sugar load is still higher than that, the gap between the sugar load and the amount of insulin your pancreas can produce is called type 2 diabetes. And then we put ourselves on oral hypoglycemics, which causes the pancreas to produce a little bit more insulin. But then if we still supersede the amount of insulin our pancreas can produce by the continuous consumption of carbohydrates, we have to fill that gap with insulin that we now are injecting into our cells. So type 2 diabetes is not a disease of the pancreas or the liver or the kidneys. Type 2 diabetes is caused by the brain and the mouth, by the endorphin center and the consumption of carbohydrates. But here's what actually happens. Here's why type 2 diabetes is harmful. If you look at your blood vessels, the endothelial cells, the cells lining the blood vessels, should look like fried eggs. This picture on the left. That is an endothelial cell. That's a healthy endothelial cell. And when these fried eggs are spread out in the blood vessels, they touch each other and they protect or cover the underlying basement membrane, the underlying layers of the blood vessel. The surface of these endothelial cells is like Teflon, and blood does not stick to them. They're anticoagulant. So blood just rushes by and brings oxygen and nutrients to the organs downstream. However, sugar is extremely hydrophilic. It loves to suck up water. When you stir sugar into a cup of water, it dissolves. It's attaching and sucking up that water. And exactly that happens inside your blood vessels. So these endothelial cells have these glucose pores, and sugar pours into the cells, and it drags with it a huge amount of water. Now, a flat vessel can't contain a lot of water. So what happens is, as these endothelial cells fill up with water, they turn from looking like fried eggs to looking like big boiled eggs, because a round sphere can hold a lot more fluid. And in the picture on the right, you see how these endothelial cells have curled up and become fried eggs. And as they do that, they expose the underlying basement membrane, and the surface of that blood vessel now is no longer anticoagulant. In other words, it's no longer like Teflon. It's now rough, like a piece of rough concrete. And it becomes procoagulant. And platelets and little thrombi stick to that. You can see the platelets beginning to stick to those walls. And you get little clots developing. And the clots block the blood vessels. And when they block the blood vessels, nutrients and oxygen can't be delivered downstream, and the organ dies. And that is the chronic effect of type 2 diabetes. Because your blood sugar is always elevated. Those endothelial cells are plump endothelial cells, and they expose the basement membrane. You get these microclots, and your end organs are dying. In fact, if you look at that lower picture, the one in red, the picture on the left shows a normal endothelial cell. You can see a huge volume of blood able to go through there. When you add salt or sugar, and remember, salt is just like sugar. It sucks up water. If you add sugar or salt to the mix, the endothelial cells plump up, and look at how much they've narrowed that lumen. Now, how does hypertension work? Well, typically, cardiologists blame salt for our hypertension. And it's true. If you eat a lot of salt, it sucks up water, and it holds water, retains water in the endothelial cells, as well as in the blood vascular space. And therefore, the heart, which is a pump, has to work so much harder to circulate this huge volume of fluid, and because it's pumping so hard, your blood pressure goes up. So they put you on a diuretic. A diuretic gets you to pee salt out in the kidney. And when you pee the salt out, it drags water with it, so you're peeing a lot of water out. So in fact, a diuretic, a water pill, is not actually a water pill. It's a salt pill that gets you to pee water out. And when you pee the water out, your heart doesn't have to work so hard anymore, and your blood pressure comes down. Well, guess what? In our society right now, we don't add a lot of salt to our food. Yeah, we do with the processed foods, but we really aren't a salt-addicted society anymore because we've recognized the harm that salt causes. But we are a sugar-addicted society, and we consume carbohydrates in excess, and they have exactly the same effect as the salt. So more and more prevalent is hypertension related to obesity, but it's not related to the obesity. It's related to the chronic excessive carbohydrate consumption. Those sugars are toxic when you consume them. And here's again the paradox. You get this really healthy, fit guy who goes and has this sugar-containing breakfast, and then he goes for a run. He burns off the calories, but the toxicity has happened at the beginning. He's done some end organ damage through the diabetic mechanism, even though he doesn't have diabetes. His blood pressure has gone up and then down. He's had some hypertensive effects. And on top of that, he's caused his cholesterol, his bad cholesterol, to go through the roof. So the Lipitor man out there is saying, man, I eat healthy, I exercise, but my cholesterol's bad. Thank God for Lipitor. But guess what? He doesn't need Lipitor. He needs to change his addiction to carbohydrates. That Lipitor man probably had a wonderful glass of natural Florida orange juice, a big bowl of oatmeal, and a bowl of fruit. Healthy diet, isn't it? Man, look how disgusting that diet on the right is. Fried eggs and fried bacon. Oh my God, that's so bad for you. And a cup of coffee? Caffeine? Which diet is better for you? The one on the left is actually drug. The one on the right is actually nutrients. And remember this. If your hunger center is not activated, you don't need to eat breakfast. So the healthy breakfast is either bacon and eggs and a cup of coffee or nothing. And the bad breakfast is the one that our society currently promotes as a healthy breakfast. So when that runner eats that breakfast and he runs off the calories, his blood pressure's still gone up, his blood sugar's still gone up, and he's produced a lot of bad cholesterol. That's why he's on Lipitor. He eats bacon and eggs and goes for his run. He's going to be in great shape. He doesn't need his Lipitor. And let me show you why. And here again is part of the indoctrination of our society. Look at this marketing. Look at this marketing. Oatmeal helps remove cholesterol. Look, there's a beautiful, healthy heart on that can of oatmeal. And the oatmeal says weight control, helps to control your weight. Garbage. And let me prove to you. So that's the belief. That's the indoctrination. That's what we buy into. But there's no factual basis to support this. And let me show you why. In that little picture at the top, you've got the nutritional facts of Chips Ahoy chocolate chip cookies. And you've got the nutritional facts on oatmeal. The total carbohydrate content of both is 27 grams. 13 and 12 grams of sugar. They're identical in their sugar content. Huge, massive quantities of sugar. But one is healthy, according to the manufacturer, and one is unhealthy. How does all of this work? How does cholesterol lower your cholesterol? How does oatmeal lower your cholesterol? Or in fact, does it? And the answer is no, it does not. The way that our bodies function from a cholesterol perspective, cholesterol is a vital nutrient. We have to consume cholesterol. It is part of a normal human being's nutritional requirement. So, let's say you eat your bacon and eggs in the morning. Oh my God, that's so bad, it's got so much fat. No, it's healthy. That's what our bodies are genetically primed to eat. So you eat your bacon and eggs. You eat 200 or 300 milligrams of cholesterol in your bacon and eggs. But that cholesterol is HDL. It's good cholesterol. And your body absorbs it and your liver processes it. It's been doing it for thousands of years. And it's good cholesterol that can now combine with the protein and the fat that's been turned to a little bit of sugar and some fat and get stored in the fat stores. So if you look at the algorithms over here, if you have if you have liposis, which is where you're creating fat, you're creating healthy triglycerides, HDL, combining to form those fat globules that go off to the fat stores, and insulin helps them to go into the fat cells. That's a healthy storage of fat. That's good fat. That's good dietary fat. What does oatmeal do? Well, fiber absorbs cholesterol. So you eat the cholesterol, you eat the fiber, you eat the cholesterol, the fiber sucks up the cholesterol and you poop it out. So you're removing your good cholesterol. Your good dietary cholesterol is being pooped out. Now what about the bad cholesterol? Where does bad cholesterol come from? And if you look at the picture on the left, we're taking fructose as sugar and we're converting it to VLDL and triglycerides. VLDL, very low density lipoprotein, is one of the bad cholesterols. It also is LDL. So what are the bad cholesterols? VLDL, LDL, and the bad fat, triglycerides. So we're converting our sugar to bad fat. And some of that cholesterol is going into the bile. Some of it is forming our gallstones. That's why we get gallstones. Not from the consumption of cholesterol, but by the production of cholesterol from sugars that we consume. But some of it does go into the gut. But it's the bad cholesterol. And the oatmeal absorbs that and poops it out. But because the oatmeal contains so much sugar, it's absorbed a small amount of good and bad cholesterol and poops it out. But it's produced a massive amount of bad cholesterol. And our cholesterol values in our bloodstream go up when we eat oatmeal. They go down when you eat bacon and eggs. Because when you eat bacon and eggs, we're not consuming sugar, therefore the liver is not producing bad cholesterol. We're using the good dietary cholesterol to combine with the triglycerides that are being formed from the fat and the protein we've eaten, and that good cholesterol and triglycerides are being stored as fat energy to be used between meals. But when we eat sugar, we're producing bad cholesterol. So the whole concept of cholesterol control should not be related to the consumption of fiber and less fat. It should come from reducing the thing that gets turned into bad cholesterol, which is sugar. So bad cholesterol comes from production, not from consumption. And the sugar content of the oatmeal far outweighs any minor fiber protection. That's the truth, not what Quaker Oats tells us. I said before that it is impossible to be fat and healthy, and that carbohydrates have a toxic effect at ingestion irrespective of your age. Jennifer Richards, who was an MPH student in our office, did a wonderful, wonderful study looking at exactly this. Because when we're dealing with kids, we say, oh, you know what, they may have gained a bit of weight, but they're not that sick. We don't have to deal with their weight right now. Let's put them on a diet, but we certainly shouldn't be doing anything drastic like surgery or anything like that. We'll deal with that when they're adults. We should wait until they're adults. Okay? If your kid was a smoker, you're not going to say, well, the smoking is not that harmful to them. We'll deal with their smoking when they're 20 years old. That's ridiculous. You're going to deal with smoking right away and use every tool you possibly can, because it's easier to get a kid to stop smoking than someone who's been smoking for 20 years. But the message isn't out there. These kids are way, way sicker than we expect them to be because of their carbohydrate consumption. And the earlier you intervene, the sooner you help to turn around those diseases. Don't help them to lose weight, help them to address their carbohydrate addiction. And here's the proof. We looked at 110, or Jennifer looked at 110 kids, there's a demographic breakdown, in our practice over a 3-year period. So the study was conducted over kids that have been in the practice for 3 years. The average age was 16.4 years. The range was from 10 to 20 years of age. All these kids were severely morbidly obese based on adult criteria, and even fatter based on childhood criteria. So their initial BMI was 46.1 when they came into our office. 3 years after surgery, the average BMI was 29.8, so a huge reduction in BMI. But what Jennifer did is she looked at the patients who came into the practice, which of them had been diagnosed with comorbidities, and when we looked at them and tested them for those comorbidities, what was the true incidence, and then how could we improve that with surgery and with our carbohydrate addiction model. Well, unfortunately, pediatricians and primary healthcare workers do not do a very good job of testing their patients. So a lot of the patients who came to us weren't even tested because the pediatricians assumed that they didn't have those diseases. So historically, when we looked at 3 diseases, hypertension, dyslipidemia, and type 2 diabetes, only about 12% of patients who came into our practice had a diagnosis of hypertension. Yet when we evaluated them, 42% of them fell out above the 97th percentile for blood pressure for their age. Nearly half of our patients already had hypertension. 3 years after surgery, only 6% still have hypertension. Okay? When we look at dyslipidemia, high triglycerides, high total cholesterol, high LDL, or a very low HDL, the protective cholesterol, only 8.2% of patients coming to our practice had a pre-existing diagnosis by their pediatricians. And yet 30% of them, 1 in 3, had dyslipidemia. And we reduced that 3 years after surgery down to 16%. Same as type 2 diabetes. Only 15% of our morbidly obese patients were diagnosed with type 2 diabetes, yet 28% of them, nearly 1 in 3, actually had type 2 diabetes. And we were able to reduce this number to 8.8%. Why not to 0? Why not to 0? Because not every patient is perfect. So there's a certain percentage of patients who didn't necessarily follow the carbohydrate addiction model as closely as they could have. But the majority did, and they decreased or eradicated their disease. Why is it important to address carbohydrate addiction early? Well, I've shown you the comorbidities that develop, but there's so many other things associated with it, things that may be permanent. Think of the psychological damage when a 12-year-old gets kicked off her dance squad because she's too darn fat. And this is in Mississippi. Within 1 year of her surgery, this young lady was not only back on the dance squad, she was the soloist because she was a darn good dancer. My patient Cody came to me after he'd already had a hip replacement at the age of 15. His morbid obesity resulted in a fracture of his hip and necrosis of the neck and the head of the hip, and that required an artificial hip. If he wasn't as fat as he was, he probably wouldn't have had that. But here's Cody before and after pictures. If he was the lower picture, he probably would have needed his hip replaced, and he would still be playing football. The girl on the right, look at her. That picture just tells a story. Here's a fat girl who's depressed beyond belief. She's on Prozac, on lithium, on Abilify. She's been Baker-acted and had in-house treatments. She's cut. She's tried to commit suicide. Look at the restoration of a sense of self. Look at this girl 3 years later. Off all her medications, well-balanced, happy, healthy. Recovering not only from her obesity, but from her depression and a variety of the other illnesses that have ailed her. So who becomes fat? Who is the vulnerable population? Well, there are a group of us who are at risk for addictive behavior. We're not talking about vulnerability to obesity. Obesity is not a genetic disease. Obesity is not a genetic disease, but there is a vulnerability to addictive behavior. And if you have an addictive type upbringing or an addictive personality, and a drug of choice becomes readily available, that becomes what you become addicted to. So if your whole family smokes, you're probably going to be a smoker. Similar with alcohol. And now, everywhere there are carbohydrates, so the most likely thing is that we become addicted to carbohydrates. Who has this vulnerability? Well, there's a small group of people that have attachment disorders. This is where there's a primary stress that doesn't get ablated by the source of the stress, but gets sublimated. What do I mean by these big words? Well, let's say a baby has a poopy diaper, and instead of mom changing the poopy diaper that's irritating the baby, and that's why the baby's crying, mom just plugs the bottle into the baby. He's just stepped 10 minutes ago, now he's had his bowel movement, and instead of changing his own diaper, mom is feeding him again. And that gives the baby pleasure. So what the baby learns to do is to deal with the emotional distress that it's feeling and the discomfort that it's feeling by triangulating a way towards something it eats and drinks that makes it feel good transiently. So it associates the consumption of carbohydrates with the resolution of any stress factor out there. If it's cold, if it's pooped, if it's lying in an uncomfortable way. What breastfeeding does is it helps that child to bond better to the mom. Mom is more attentive. She's going to take care of the true need of the baby rather than just plugging it in for any need. So attachment disorders are a very early source of association with carbohydrates. This can even happen in utero. Let's say mom's pregnant and mom is totally stressed out and she eats a tub of ice cream to deal with her stress. Well, that hormonal milieu in that uterus is giving the baby exactly those feedback signals. Mom is stressed out, the stress hormones are going along, mom eats a tub of ice cream, my blood sugar goes up, and I feel better. So down the road, once that baby's born and it gets exposed to carbohydrates, it links that with a sense of well-being, and even in utero you can prime your baby. But let's say mom goes for a run. She's stressed out and she goes for a run. And the hormones that now get secreted both in the mom's body and in the uterus that are associated with running or with physical activity calm the mom down, calm the baby down. The baby attaches to that as well. And when that baby is born and it has the same hormonal milieu of stress, and then it goes for a walk or a run or it plays a game of basketball and it alleviates that, baby's feeling better. So we can prime our kids in utero. There's a small percentage of people who are vulnerable to addictive behavior because of some catastrophic event that happened in their lives. Think of the Sandy Hook kids. Think about how the survivors from Sandy Hook, how psychologically disturbed they are. Or, for example, mom gets divorced, stepdad moves in, and has this uninvited incestuous relationship with his stepdaughter. Stepdaughter blames herself. She's all this guilt feelings. Guess what? She's vulnerable for addiction. Okay? But the most widespread issue is parenting style. This is by far the most common source of vulnerability to addictive behavior. Nobody teaches a parent how to be a parent. We teach parents how to feed their kids. We teach them how to clothe their kids. We teach them about school. We don't teach them about how to raise their children from a psychological perspective. And that is so important. And we pediatricians and people that work with kids, if we understand this, can help the parents and teach the parents this up front. There are 4 parenting styles. The first and 2 of them, very commonly in various forms, lead to addictive behavior. The first group of people are the permissive or hedonistic parenting style, where there's very little structure, and rules are really treated like speed bumps. You slow down, but you say, screw the rule. Didn't want to do it now. This is the fat, happy family. Everybody's fat because everybody is using the lowest common denominator to satisfy their emotional needs. It is so important for a child to put effort into something, and the return on the investment of effort, the success that that effort achieves, develops a sense of self. Effort breeds a positive self-esteem. But effort requires effort. And if you are required to put effort in, but the effort becomes too much and you walk away from it, you really don't develop a positive sense of self. So in the hedonistic group of people, they treat effort as something to walk away from and go and find something easier to do that gives you pleasure, such as eating or drinking something. Rules are speed bumps without consequence. They have trivial goal setting, they blow off mistakes, mistakes become irrelevant, and they really never establish a need to learn. So for example, how does the fat family work? Well, you know what, Johnny? I think you should eat some broccoli tonight. Broccoli's good for you. I think you should eat that. Okay, Mom, I love broccoli. I'll eat. But you know what, Mom? There's a piece of pizza in the fridge. Let me do this. Can I eat the pizza tonight? And I promise you tomorrow I'll eat double the broccoli. Okay. So Johnny eats the pizza, and guess what? Tomorrow never comes. Tomorrow there's another excuse. So any time that adversity or effort is required, they walk away, they divert from effort, and find something more simple to do. So they never establish a sense of self, they never establish rules or boundaries or structure in their lives, and their lives are devoid of structure. So very easy to see how they readily turn to substances that satisfy them, and because they don't have structure, they continuously consume those erroneous substances in excess. The other group is the diabolically opposite group. These are the authoritarian families. And these are tough, tough, tough kids to deal with. This is where it's typically, not always, but typically the skinny mom with a fat kid. That mom who desperately, desperately wants her child to achieve. She's doing everything she possibly can because results matter. Success matters. And it doesn't matter how the hell you get to the success. You got to put the effort. You got to do it. But the effort is irrelevant unless you achieve the success. They set ridiculously high standards, have ridiculously structured environments. And while the child does put a lot of effort in, the effort is never quite good enough. These kids develop a very distorted or eroded sense of self because anytime they put effort in, anytime they're proud of the work they did, it's just never quite good enough. They're never allowed to make mistakes. And we learn from our mistakes. So if you're not allowed to make mistakes, you lie about them. Oh, it was this person's fault. The teacher was bad. The other kid did this. Or you should. They never ever take ownership and personal responsibility. Therefore, they can never ever develop a corrective action plan. So they never learn. They get told what to do incessantly, and they never ever learn. They get taught all the time. These are strict rules with harsh consequences, ridiculously high expectations, and instead of the kid having a sense of well-being, the kid develops a sense of dread and is petrified of screwing up. So instead of expunging emotions and absolving emotional distress, they're absorbing a huge amount of emotional distress. And then they triangulate to something that's inanimate, something that's readily available, something that is non-judgmental that makes them feel better. And it's typically the consumption of substance. So they establish at-risk behavior patterns for addiction. These kids are very, very difficult to deal with because there's such a distorted reality. So let me give you an example of this kid. This is the kid where Johnny comes home and he says, look, Mom, I studied really hard for my math test. I came second in my class. I got an A. Well, who came first? Who got the A+? Why did you get an A+? What question did you get wrong? Focusing on the lack of success, not on the greatness that the child did. No return on the investment. This is the child that Mom says, here, Johnny, here's your broccoli. This broccoli is good for you. You will sit at this table and you will finish this ridiculously large plate of broccoli. And if you don't finish it, you'll go to your room without any further supper. And Johnny strangles the broccoli down. He forces it in. He feels like crap. All upset and angry because his mom has set a ridiculously high expectation of broccoli. Johnny goes off to his bedroom, and what's lying under the bed? The Snickers bar and the can of Coke that he snuck in. So that's what makes him feel better. But this triangulation is a horrible, horrible way to go. Then obviously there's a few kids that fall in the neglectful category, where there's really no parenting guidance. The parents are kind of absent. The child has a false sense of self. They think they're capable of everything, but they've really not had guidance. What you want is some guidance, some teaching, and some learning. But there's no paradigm for this child. They learn through trial and error. And the child has to create their own rules, their own boundaries, their own habits. And quite frankly, it's a hell of a lot easier to eat pizza than it is to make a salad or to make vegetables and a steak. So they drift down that pathway. But they're relatively easy to treat. Now, what should we do? Which group of patients, which group of people are never at risk for addictive behavior because of their parenting style? These are the authoritative kids. An authoritative child is one where there's shared ownership, shared responsibility within a structured environment. These are the kids where they get told what to do, but they get given a choice. I want you to do this, and you can choose whether you're going to do it this way, or this way. And when those kids fumble and make a mistake, they're not judged, they're not belittled, it's not blown off. The mistake is analyzed. What went wrong? How do we fix it? And a new plan of action is entered into to correct the mistake. These kids are praised for the effort they put in. The return on the investment of effort is a sense of well-being, and as their sense of self grows, they're able to put more and more effort in. Yes, there's a reward from the result, but primarily the focus is on the effort the child puts in, and they're learning as well as being taught. So how does this kid work? Well, this is the kid that says, you know what, Johnny, I really want you to eat a vegetable. There's the rule, there's the boundary, the structure is there, you're going to eat a vegetable. But you've got a choice. What do you feel like tonight? I can make you some carrots, I can make you some peas, I can make you some broccoli. Which one do you want? What you're doing is engaging the child, giving them some ownership of a choice within boundaries that you set. All right, Mom, I'll have the broccoli. I feel like broccoli tonight. And Mom puts a big plate of broccoli in front of the child. And the child eats half or two-thirds of the broccoli. Oh, Mom, I'm kind of full. You know what, Johnny? You did a great job. Fantastic. You ate your broccoli. Leave the rest. That's okay. Off you go and play. Johnny feels wonderful. He put the effort in. He feels good. And he can go off with a wonderful sense of self, feeling good, and go and do something else that makes him feel good. He doesn't need to triangulate. He doesn't need to find something else. He has done that within the context of an authoritative upbringing. And that's the goal. So our at-risk for vulnerable behavior, for addictive behavior, are the authoritarian and the permissive kids. And we have to recognize what parenting style is in use, because if you treat an authoritarian child from an authoritarian perspective, you're going to lose them. Similarly, if you don't have rules and uphold rules for a permissive kid, you're going to lose them. So you've got to treat these kids differently based on where they come from. That is so important. You don't want to be their mother or their father or their family. You want to be somebody that can get them out of those trappings. So, how does all this fit in? Well, everybody has emotional needs all the time. We have anxiety, boredom, depression, stress. We need pleasure. We need fear. We need that endorphin release. A healthy child has a variety of different methods of releasing those endorphins. Healthy people have diverse, balanced, action-oriented, internally generated endorphin-releasing foundations. We have fortresses of solitude we can escape to. I can go off and play the piano. I can go for a walk. I can go and do my photography. I can go to church. Healthy people have controlled snacking. We'll use snacks and carbohydrates from time to time as one of these pathways for endorphin release, but it's tightly controlled. What does a fat person look like? A fat person develops a dominant, out-of-control, excessively, somewhat exclusively used relationship with carbohydrates and snacking to satisfy all of their emotional needs. Well, in the old days, this could have been smoking or nicotine, could be drinking and alcohol, could be drugs that you snort, smoke, or inject, could be sex, masturbation, pornography, gambling. 40% of my kids cut. It's whatever they've got easy access to. It's typically a very powerful endorphin-releasing drug in a vulnerable population. And when one behavior pattern becomes dominant and excessive, bad things happen. So for the obese person consuming carbohydrates and snacking, they become heavy, they gain weight, they develop hypertension, diabetes because of the toxicity of that sugar, and they become experts at distorting or ignoring the reality of that problem and using their emotional needs to justify that, oh, I've had a really rough day. Man, I need my ice cream. Or I need my chocolates at the end of the day. So they justify and validate their consumption based on their emotional needs. And that relationship becomes out of control. So these kids typically are your ADHD kids. They have an increasing need for psychotropic, antidepressant, and behavior-modifying drugs. They act out. And what do? We put them on these drugs, and that dumbs down the ability to derive pleasure from other means, and it forces them into this channel. So, remember what I said before, that chronic excessive carbohydrate consumption causes all of these conditions. So primarily we have to help the child and the family to focus on distancing themselves from their carbohydrates, introducing healthy food that has nutritional value, that you're eating for hunger, not for pleasure, and develop alternative endorphin activating resources. So we've got to help the child to do that. We can't do that for the child. We can guide the child along that pathway. But at the same time, we also have to manage their obesity, their hypertension, their diabetes, their comorbid diseases. And that's the weight loss principles, the surgeries, the diabetic medications. We have to treat that while we treat the cause. So we have to treat the disease and the cause, but eventually if the cause is treated adequately, the disease goes away and stays away. And that's the effective strategy, because what are we after? We're after a child looking great, feeling great, being emotionally well and being healthy because of their weight loss. But we also are looking for emotional stability, a great sense of self-worth, self-esteem, the ability to learn and to tolerate mistakes. We want the child to use what they do for life to blow off emotional steam. We want to develop action snacks, not consumption snacks. We want them to do projects. And then there'll be a reduced need for psychotropic, antidepressant, and behavior-modifying drugs. When a child has good self-esteem, they use internal mechanisms of emotional management. And that's the goal. Obesity is not a weight problem. Obesity is not a calorie problem. Obesity is not a lack of physical activity. Diets and exercise programs just don't work. Then they transiently get you to lose a bit of weight, but they don't work and the weight comes back. Because obesity is a substance abuse problem. And it requires a cognitive behavioral therapy approach, a change in how we manage our stress, our emotions, and our pleasure. My first patient on the left, her surgery was performed in 2004. My second youngest patient, age 11, is seen here. Look at the results. So let's move on. Why now? Why is our society become fatter in a meteoric fashion? Why over the last 2, 3, 4 generations has obesity reached epidemic proportions? Well, it's all his fault. It's all Christopher Columbus's fault. What did he do? He sailed to the New World, and he discovered alcohol, he discovered tobacco, he discovered sugarcane. Yeah, alcohol was present, there was small amounts of sugar, there was a little bit of tobacco, but he allowed us to produce massive amounts of these. How did that happen? Well, in Europe, before Christopher Columbus sailed to the U.S., tobacco really didn't exist. Alcohol was present, but it was primarily grown from grapes. It was viticulture. It was wine and beer. Spirits really weren't around that much because we weren't able to distill spirits other than from potatoes and some grain. And certainly, sugarcane wasn't available in large quantities. In fact, in Europe pre-Christopher Columbus, when sweetness was required, it came in very small amounts in the form of honey, in the form of apples that we put into our food. We sweetened food with things that grew and things that were produced, not by processing things. So there were very limited quantities. And yes, there was still a vulnerability for addiction. If you sat and ate honey all day long, or ate apples all day long, you could become fat. But we had very, very limited exposure. When Christopher Columbus discovered the U.S., or Americas, he discovered tobacco, he discovered sugarcane, and a whole slave industry grew to satisfy Europe's demand and Europe's desperate need for these substances. So by mass producing these substances in a very worker-intense fashion, the big plantations that grew these substances allowed us to import them to Europe and to develop addictions to these different substances. So we became alcoholics, we became smokers, we became fat. And in fact, if you look at the legacy of the U.S., that same vulnerable population that I talked about in the 1900s, what was their drug of choice? It was gin, it was alcohol. In fact, we had to go through prohibition to try to limit and try to reduce the number of people that were becoming alcoholics, because it was a real problem in the U.S. Prohibition didn't just happen. It happened in response to alarming numbers of people that were becoming alcoholics or who were abusing alcohol. While we still have alcohol, the world has turned against it. It doesn't condone alcohol. It's still available, but in very, very limited amounts. But alcoholism still is prevalent. Same thing with smoking. In the 1950s and 60s, everybody smoked. The whole world smoked. It was cheap. It was ubiquitously available. Everybody underscored the dangers, and smoking was promoted as a wonderful, wonderful drug to calm us, to deal with our nerves, to help us to handle life. And that vulnerable population that we've talked about were all smokers. Well, the world's turned on smoking. Cigarettes have become far more expensive. You're not allowed to smoke anywhere. We understand the dangers, and the world has turned against smoking. We still have access to cigarettes, but fewer and fewer people are smoking. Not only has cigarette smoking become more difficult, but also another more popular drug, more favored drug, is replacing it in that vulnerable population, and that's sugar. Carbohydrates in the U.S. are ubiquitously available in ridiculous quantities. And we, over the last 2-3 generations, have become carbohydrate addicts. So it's all Christopher Columbus's fault. But I love this slide on the right. Yes, we as a society have become a slave to sugar. But in fact, what's more pertinent about this slave is that sign on his back, because really, we have also become a slave to green. And it is our slave to the dollar, it is our slave to money that is in large part in this country driving our slavery toward the addictive substances, because we make money off them. So how has obesity evolved? Well, after the Second World War, there was a worldwide hunger. There was a shortage of agricultural products that were required to deal with hunger. But as human beings, we are wonderfully resourceful. So we're able to manufacture food. So we sat down and we said, okay, let's take food, let's break it down into its simple components, and let's rebuild that in a factory and make food. We did that with breast milk. Think about this. Okay? A lot of babies have died and suffered nutritional malnutrition because there wasn't enough breast milk available to them. We used to have wet nurses, but when milk wasn't available, babies suffered and died. So we said, okay, this is a problem. Let's take breast milk, let's analyze what the different constituents are of breast milk, let's find the formula for breast milk, and let's rebuild it in our factories. And we came up with formula. And the majority of kids these days are not raised on breast milk, they're raised on breast milk formula, which is almost identical to breast milk, so identical that it replaces the role of breast milk, and these kids are healthy, and starvation amongst children, amongst babies, is nearly being wiped out. If only we had done the same thing with food, we would have been wonderful as a society. However, a second big mistake happened. There were a group of very influential nutritionists that moved from Europe after the Second World War and came to the U.S., and they had this intense belief that the consumption of fat and physical inactivity was causing obesity. They believed that fat consumption was bad and harmful to human beings. So they indoctrinated us with this misbelief, and our entire focus is fat's bad, carbohydrates are good. In fact, If you look at that picture in the top left, that slice of bread with a lovely piece of butter on it, most of us say, oh my God, that's disgusting. How can you put so much butter on the bread? The bread is brown bread. It's so healthy, but the butter's so bad for us. Well, guess what? That's our belief. That's what we've been indoctrinated with. But that is totally wrong. It's exactly the opposite. The butter is actually the healthy part, and the bread is the enemy. Oh, you're so wrong. You don't understand. Guess what? 50 years ago, they were telling us exactly that about smoking. Look at the picture on the right. This is an advertisement for Camel from the 1950s. Most doctors smoke Camels more than any other cigarette. I'm going to live to be 100 years old because I smoke Camels. Think about that now. Do you know any doctors that smoke Camels in ridiculous amounts? No, they all smoke Marlboros. No, I'm kidding. Doctors no longer suggest that you smoke Camels. In fact, quite the opposite. We've learned. But in the 1950s, that was an honest belief because we didn't understand the dangers, we didn't understand the harm, and it was a wonderful drug that gave us so much pleasure. So how could something that's so pleasurable and so valuable to us cause us so much harm? Well, we now understand that about cigarettes. We are, with regards to carbohydrates, where we were with nicotine in the 1950s and 60s. We've been indoctrinated with a misbelief that fat is bad, that carbohydrates are good, and the paradox is that the more we've blamed fat for our obesity, the fatter we've become in this country, and the more metabolic syndrome rates have climbed. So when we've done all this removal of fat from our diet, we've become fatter and more sick. That's the paradox. So it can't be true that fat is bad and carbohydrates are good. In fact, the other funny thing is, if you look at this beautiful film Casablanca, where Bogey and Bergie play these wonderful roles, what was involved? If you look at historically the things we did from an endorphin reduction perspective, 1942 the film was made. There was only one fat person there. Everybody was skinny, 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 rail thin. But in every scene they smoked, in every scene they drank, and it was all about this intense sexual tension as well as war. So a number of alternative endorphin-releasing things. There was alcohol, there was nicotine, there was love and sex, intrigue, and there was war. There was fighting, there were battles, there were arguments. People fought. They weren't politically correct. So a wonderful variety of different things, some good, some bad, but most of those have been taken away from us. So there is no factual basis to support the fact that fat is bad and carbohydrates are good. In fact, quite the opposite. But when we removed fat from our manufactured food, the food tastes like crap. It tastes terrible. So what did we do? We started adding fructose corn syrup, gluten fillers, carbohydrates, all replaced the fat in our diet. So, for example, if you take the modern processed food, it starts with something that was manufactured, some sort of a gluten filler. So, for example, you take a hamburger. You've got this gluten filler. The state law says that in order to call something 100% beef, you have to add up to 22% of beef into that burger, and it shouldn't have contained any other sources of animal protein. So you put 22% of beef in amongst this filler, and you add a few flavoring things, and you say this is now a hamburger 100% beef patty. Okay? Carbohydrates have allowed mass production through food processing, and then we add nutritive additives to it and call it healthy. So you've got this vitamin water or flavored water. It's water, it's needed for thirst. It doesn't need to contain calories, and it certainly doesn't need vitamins and minerals and everything else. We get those from our food, or we should. But what this resulted in was easy access and availability of certain food types, enough to keep us alive, available to everybody. So we solved hunger, but what we didn't recognize is the powerful endorphin stimulatory effect of carbohydrates. So while we've solved hunger, we have created malnutrition and obesity. So for the first time ever, society is condoning easy access and ready availability of a very toxic, powerful endorphin-releasing drug, carbohydrates, to our children. We're promoting drug addiction. We've concentrated the manufacture of these carbohydrates. We've made it very convenient. Before, a parent had to prepare a meal for a child. Now a child can go to the fridge in the pantry and the store and just grab something. and eat it. No preparation required. Production, manufacture, packaging, portion sizes, marketing, costs have gone through the roof. Why? Because we make money off this. And we distort the nutritional facts, and we make them misleading to have people buy our products. Think back to that Quaker oatmeal advertisement. And everybody's an expert. Everybody's trying to tell you that this magical formula, that magical formula is so good. The diet and exercise models just don't work. On top of the ready abundance of a drug that we call food and drink, we are also progressively depriving our kids of alternative endorphin-releasing mechanisms. We've reduced the source of action-oriented stress management and endorphin release. There's less activity, less exercise. We give our kids less free play time, less imagination time. We don't give them that fortress of solitude anymore. And the fridge in the pantry has become their fortress of solitude. The kids have more screen time. We say, oh, it's unsafe to go outside. We have safety concerns about allowing kids to be kids. Schools and rules and shit. The schools have become full of rules. Full of rules. Kids have to do this, kids have to do this, that. And they don't want to swear anymore. Think about how you felt when you saw that word shit in there. Well, shit's a wonderful endorphin-releasing word. We don't use it anymore. It's bad. We punish our kids for using it. Neighborhoods are disappearing. We have less friends. We have more organized activities and less free time to play and think about playing. There's too much teaching and too little learning, too little experimenting. We're not allowed to fail. And certainly we're getting a lot less sleep. So obesity is not a hunger or a nutrition problem. It's a pleasure problem. And we're giving our kids ready access to a drug for their pleasure while depriving them from a variety of other sources of pleasure. So if we want to understand obesity, why we eat, we should be eating for thirst and hunger centers, but instead we're primarily eating for pleasure in our endorphin center. We should be eating regulated meals in response to our hunger. Instead, we're eating opportunistically whenever we have an emotional hunger. We should be satisfying our body, our somatic hunger, but instead we eat in response to our emotional hunger. We're eating drugs, we're not eating nutrients. However, while we have exposure to all of this, harm only occurs when we do these things in an uncontrolled, excessive manner. And that is where the vulnerability to addiction occurs and where our parenting styles are so in need of correction. So let's go on to treatment. How do we treat patients? Well, we treat this from a substance abuse perspective. And I have modified what the alcoholics use as a foundation of their method. And here is my serenity prayer. Grant me the serenity to accept the things I cannot change. Courage to work hard at changing the things I can, and the wisdom to know the difference. Live one day at a time. Enjoy one moment at a time. Accepting hardships as the pathway to improvement. Taking this imperfect world as it is, not as how I would have it. Trusting that good enough is good enough if the effort is put forth. That I may be reasonably happy in this life and content with my assets. Mind, body, soul, and circumstance. You know, the American dream when I came to this country was thought to be, have as much as you possibly can have. But at a certain point, we become a slave to servicing what we have. And quite frankly, the American dream is to have enough to be happy, but not so much to be burdened by it. So be content with your assets. Mind, body, soul, and circumstance. So when we treat obesity, there's a pyramid, and we add layers to the pyramid. It's not one or the other. They're all part of the same process, and it's an additive methodology. We start with lifestyle changes using a cognitive behavioral therapy model. We have to help our patients to divorce their relationship with carbohydrates, snacks, and calorie-containing drinks, and find other ways to release those endorphins. Physical activity, what I call action snacks, little things that we do that give us pleasure as opposed to little things we consume. On top of that, we also have to teach our children what is an appropriate diet from a nutritional perspective. What things can we eat and drink to be healthy and to derive some pleasure? This is a process of change. This is a process of change. We have to get people out of the pre-contemplative state of the misbeliefs that we've been indoctrinated with over the last 2 to 3 generations. We have to have people contemplate their source of endorphin release. And this brings in the carbohydrates and other sources, and then prepare them for change. It's a progression. You don't have to do everything at once. Give up the sodas and the drinks first, then move on to the snacks, then move on to the rice and the potatoes, then move on to the other things. There's ways to begin our preparation. Begin by going for a walk. Begin by starting to take photographs with your cell phone, and then get into photography. Start going to church once a week, once every other week. Start going for a walk on the beach. Start playing a musical instrument. It doesn't matter what floats your boat. Begin those things. And once you've got that in your head, once you're starting to try certain things, we can intervene with more aggressive mechanisms. The lap band, certain medications, certain temporary devices, these are wonderful to help people to begin the weight loss journey, but they've got to simultaneously address their addictive personality, their carbohydrate addiction. So we have to do the two contemporaneously. We have to set a lifestyle change paradigm and then begin to use devices, medications, and possibly even surgery to help people to lose weight and to reduce at least transiently the comorbidities while they address the cause. Unfortunately, in this country, the FDA has placed severe limitations on the variety of temporary devices and medications that we can use, and even the directions for use of the lap band have been radically limited by the FDA in their zealousness to protect the American people. Well, guess what? We're becoming fatter and fatter and fatter, and we really have no tools to effectively combat that. That's a problem. But we've got to understand the process of change. Our patients have to be taken in order to be successful through a stepwise process from pre-contemplation to contemplation to preparing for change to having an intervention, having a start date where they put their preparation, their plans into action, and then continue to practice those and be consciously aware of them until they become a method of maintenance. And then we've got to handle screw-ups, because we all do. How do we restart the process? How do we re-engage? All of that becomes part of the obesity treatment pyramid. So in our multidisciplinary cognitive behavioral therapy model, what we do in our practice is at first contact, we get the patients in and we give them new hope. We tell them that they've tried all these diets. They're experts at failing diets and weight loss programs. We give them ownership of the true source of the problem. We discuss the carbohydrate addiction model, and we give them new hope that they can fix this. In the pre-care part, we have to analyze and understand the family dynamics. Is this an authoritarian child? Is this a permissive child? And we have to engage the child from that perspective. We have to introduce a capacity for change. Yes, you can. John F. Kennedy said you can take a massive problem and break it down into tiny little bits that makes it so much easier to solve. And we do the same thing. Give the child small amounts of things to do. Make your bed every morning. Not perfectly, just pull it up. Get rid of the sugary drinks and bring something in that's not sugary. Little things that we can begin to change, and then we build on that. And during that time, we build a relationship of trust with the family and child. We develop a concept that change can happen. Then, from that preparation and planning phase, we go into action. And this may involve medications, devices, or surgery to help the person to divorce their relationship from the carbohydrate. We have to break habits. We have to break relationships without an immediate return on that investment. We have to stop snacking, get rid of the carbohydrates. We have to bring rules that have consequences into play. We have to introduce an effort-based framework of emotional management. This phase has rapid weight loss and comorbidity improvement. And as you lose a certain amount of weight, good things do start happening. And then you enter the next phase. As these good things happen, you go from the divorce phase into the success phase, where when you lose enough weight, you're able to use the increased things that you can now comfortably do, psychologically or physically, to develop new diverse strategies for emotional emancipation. We can develop a variety of different action snacks, projects that we can now start doing, developing creative new habits, and having a better relationship with ourselves. When you put that effort in, your self-esteem grows in little increments. And there's no guilt attached to that. When you eat a carbohydrate, it makes you feel good. But there's a little bit of negativity and guilt that's attached to it that erodes your sense of self. When you go for a walk, when you play the guitar, when you sing a song, it makes you feel good. The return on the investment of that effort is a good feeling without contamination by negativity or guilt that builds your self-esteem, that allows you to do more. So our goal is a new foundation to deal with life and assess a restoration of a sense of self. In the aftercare program, we maintain ongoing contact and reinforcement. Patient comes to visit us on a regular basis just for that touch, for that movement forward. Change continues until the day you die. We aim for a successful transformation of management strategies from an emotional perspective, and that sense of self. And if patients fall, we have a multitude of pharmacologic, temporary devices, and possibly even surgery to help them back on the track again. But the program is the cornerstone. So, let's move to surgery. How does weight loss surgery work? Well, the role of surgery is to reduce calorie consumption, to get you to lose weight. Remember, it's weight loss surgery. It's not obesity management. That the patient has to do. So, the role of the surgery is to reduce calorie consumption and give patients early, prolonged satiety that results in weight loss. However, human nature is to restore the status quo. And what people very rarely do, they lose some weight as the surgery works, but then we try to figure out a way around our surgery. We try to beat the system. We try to restore the status quo and we gain weight back. So the obesity management program, during that time of rapid weight loss, needs to modify the source of endorphin release so we don't go back to the carbohydrates. It is important to understand, and most people don't, most bariatric surgeons think of surgery as being a permanent, successful tool. It is not. Surgery is not permanent in terms of its effect. The effective durability of weight loss after surgery is only 1 to 3 years, irrespective if you have a lap band, a sleeve gastrectomy, gastric bypass, duodenal switch. The effective duration of weight loss is only 1 to 3 years. So therefore we have to use surgery as a tool to help us to reduce our excess weight, not as a magic bullet. Not as a magic bullet. It works well from a comfortable starvation perspective during those 1 to 3 years. But after that it levels off, and then you keep the weight off or regain weight based on whether or not you go back to eating the carbohydrates. So while the effective durability of weight loss after surgery is only 1 to 3 years, we've also got to understand that the durability of the changes we make at surgery, the operation itself, the effect of the operation on the body is permanent. It's lifelong. So therefore a patient has to live for the rest of their life with the consequences of what we do. And if there are going to be complications related to what we've done, the patient is going to have to bear the burden of those for the rest of their life. Therefore, in my practice, we choose the most effective, least destructive, least invasive, safest surgery that still has a positive weight loss effect. And that's the way I decide on surgery. Therefore, in my practice, I absolutely will not do a biliopancreatic diversion. Yeah, starvation gets you to lose weight, but it's miserable. 50+% severe operative and malabsorptive complication problems down the road. Bad operation. Not in terms of weight loss, but in terms of bringing on a new set of complications and comorbidities. Gastric bypass in a child. Gastric bypass is a very, very effective surgery to lose weight. It's called comfortable starvation. You can't eat a lot, you feel like crap when you eat carbohydrates, you lose a lot of weight. But that's for 1 to 3 years. However, you've got to live with these changes for the rest of your life. And the problem with gastric bypass is it's in its technical and malabsorptive malnutrition complications. Pretty close to 100% of people who have a gastric bypass will have significant complications at some stage during their life. And it is because of the burden of these complications that I have decided not to do gastric bypass. Nice operation to do, good for weight loss, but bad in the long run for the patient. So certainly in adolescence it should not be done, and I'm very adamant about that in my practice. The sleeve gastrectomy is a good operation. It is still a destructive operation, but it is a weight loss by comfortable starvation operation. It's where we remove approximately 90% of the stomach, and long term this is going to have consequences from a metabolic perspective, but not as dramatic as the gastric bypass. So I love the efficacy, the weight loss that you get after a sleeve gastrectomy. I'm a little concerned about the complications, especially the long-term ramifications. So sleeve, great weight loss operation, a little concerned about the complications. The lap band is a wonderful, wonderful operation in terms of reversibility and a lack of complications. Look, I put the lap band in my reversible or my temporary device things, not in my surgical paradigm on that triangle, because the lap band is reversible. It's adjustable. Wonderful from those perspectives, but here's the problem with the lap band. It's so darn easy to cheat on. It's so easy to cheat on. And what we do is the physician then overuses the lap band. They take the lap band from being a tool to being from being a restrictive device to being an obstructive device. And then bad things happen. The esophagus swells, the band slips, the band erodes. Bad things happen when the tool is used in an excessive way by the physician, or if it's not been put in properly. So the band is a wonderful device, easy to beat, but very, very safe and very effective when used by an experienced surgeon who doesn't overuse it. So the ideal situation would be to have the weight loss efficacy of the sleeve and the safety and adjustability of the lap band. And one of the newer surgeries that is still investigational is that wonderful operation. It's called the banded imbrication or banded plication. This is where you put a lap band in like normal, and instead of removing the stomach, you fold it in. So in essence, if you look at the bottom, you create a sleeve gastrectomy, but the stomach is folded in, not removed. And this provides a wonderful, effective weight loss period for the first 1 to 3 years, but it is reversible. And you've got the adjustability to recapture patients down the road. So to my mind, the long-term better operation is the imbricated lap band. But the FDA has come down with ridiculous rules. You need an IDE to do this. It's got to be considered experimental. You have to have all these checks and balances to assure the safety. Well, we know the safety. I've done over 400 of them. But still, I cannot do this outside of the context of a very tightly regulated controlled trial. So there are some concerns about how we use these surgeries. You can do a gastric bypass on anybody at any time. But to do a banded imbrication, you've got to do it within the confines of a study, so it's being underutilized as an effective tool in our community. The results of bariatric surgery in my practice have been wonderful. Early on, these are 400 patients that we performed lap bands on. First 3 to 4 years, wonderful, wonderful results. However, and I haven't shown this because I haven't done the study on this, but I can tell you that as patients get further out, as they distance themselves from the practice over time, weight regain does occur as they slip off back into carbohydrate consumption. So the concern with the lap band is that it's very effective when they're in the tight confines of our program, but because it's so easy to beat and cheat, they gain the weight back. My concern is there also for the sleeve gastrectomy and the other operations, but we need something a little stronger than the pure lap band, and that's where the banded plication comes in. And if you look at the results from that earlier study that Jennifer Richards did, that study was done on patients who had banded plications. Ultimately, for our kids, they don't care so much about the diseases, the complications. It's really about how they look, how they feel, and how they function. And this is a group of my patients who have done extraordinarily well. And just by looking at these pictures, you can see they are different human beings, psychologically, physically, and metabolically. Now, there are some wonderful new strategies coming down the road, some wonderful tools that we are going to be able to use. Unfortunately, the FDA requirements are set so high that none of these are currently available. But the ultimate approach to weight loss management, to the weight loss side, not the carbohydrate side, is multimodal, sequential, using temporary devices at various times in that individual's pathway, using procedures and medications, and using them on top of each other, together with each other, in sequential way, to help patients from the contemplation stage to the success stage to the maintenance stage. And as you can see, this is how the marketplace is going to evolve. These things are already available, and here they are. So we've got a variety of different things, from probes being put into people's brains to adjust the endorphin center, to little things that go under the palate to affect oral volume, to stomach fillers, the full bar, the gelasis gel polymers, to vagal nerve stimulator that makes you feel full, to drugs that work, chemicals that work at the endorphin center, the phentamines and the pharmacologic neuromodulators, to a variety of devices that get put in the stomach, a variety of different balloons. I've been involved with the early Obalon trial, which I love as a device, different sleeves and condoms that fit in the stomach, all designed from a temporary intragastric perspective to help people to consume less, to feel full earlier. And a variety of different suturing platforms that can be done through the throat, through the mouth. For example, Apollo Endosurgery now has the Overstitch device where you can narrow down segments of the stomach and create that plication or that imbrication from the inside rather than the outside. All future technology, all stuff that's now being experimented with, all wonderful ideas, but they still have to come to fruition. So all of those things are part of the obesity management program of the future. But right now, we're still dealing with carbohydrate addiction. We do not have a drug or an effective mechanism of treating carbohydrate addiction other than helping the patient to treat themselves. But we do not want the shape of things to come to look like this slide. We want to go backwards slightly on this slide. But remember, the greatest addiction is the one to green. It seems ludicrous that we can still sell cigarettes now that we know how harmful they are, but yet we still do. So ultimately, yes, we have to stop selling cigarettes. We have to put our addiction to dollars aside. But until that time, what can you do? Well, the first step is to separate the indoctrinated beliefs that we as a society have believed in. Fat is bad for us, diet and exercise are the way to go, surgery is bad. We have to separate those beliefs from the real facts that I've tried to present today. We have to heal ourselves first. We have to start understanding that cigarettes are probably not a good thing to smoke. And once we come to the conclusion that physicians probably shouldn't smoke, and we have to help our patients to quit smoking, we can then be part of the anti-smoking lobby. Obviously, it's now to do with carbohydrates. So once we come to the conclusion in our own heads that carbohydrates are a problem, we can then begin to help our patients. The most effective way to help people is to reduce the likelihood that they have a vulnerability to addiction. If we understand parenting styles, we can actually teach our young parents how to be effective parents from a self-esteem, effort-based perspective. If we can teach parents an authoritative parenting style, we are going to lessen vulnerability to addiction despite the prevalence of addictive substances. If we can teach our parents to be effort-based rather than goal-oriented, and put praise and put rules in place to generate that effort. But what we want to do is create distinct boundaries, yet share ownership of what goes within those boundaries with our children. Give them choices within those boundaries. Allow them to earn praise, to enjoy the success, but earn praise both for the effort and the success achieved. And very importantly, have a dynamic corrective action plan available, where when mistakes happen, when things don't go quite as planned, we develop rapid ownership of the fact that something did go wrong. That in a non-punitive, non-judgmental way, we can analyze with the child what did go wrong and come up with a corrective action plan, come up with a correction, so they can re-engage and correct the problem. If we can raise our kids in authoritative ways, we are going to avoid the vulnerability to addiction for the majority of our patients. Additionally, we need to educate our families. Educate them about carbohydrate toxicity, not just in terms of obesity, but in terms of disease. Help our families to understand what nutrition is about, that carbohydrate is a drug, and help them to develop and understand the need for a balanced endorphin activation mechanism. The reason to exercise is not to lose weight. For some of us who enjoy exercise, it is to get high. It is for the endorphin high that we exercise, not the calorie burn. Fat people who exercise to lose weight end up gaining weight. Fat people who give up carbohydrates and start exercising because they now feel good about exercising and they don't use carbohydrates to feel good, lose weight, keep it off. Stop promoting diet and exercise as weight loss strategies. More importantly, allow families to understand that their kids may have a problem. Measure obesity using those CDC BMI tables. Show the parents where their kids fall out on those tables. Measure comorbidities in your patients. Measure them, track them, and follow them. Because the earlier you intervene with guidance, with medications, with devices, with surgery, the better off your patient's going to be long term. And if you're not able to do that yourself, or if you hit a wall, or if there's recidivism, refer the patients and the at-risk families for further education, further evaluation to our program. And finally, be a community activist. Talk to the schools, activate at the school level, activate at the community level, activate at the governmental level to reduce the exposure of our kids to these harmful drugs. Remember, what floats her boat will determine how her boat floats. Will she play the piano for her endorphin release that you see in the background? Will she eat the butter for her nutritional value, or will she turn to the bread, the carbohydrates, for her emotional management? What happens to this child is determined by how, in large part, by the guidance that we give to the families as physicians. We've made mistakes. We've clearly gone down a pathway of misbelief, just like we did with smoking, just like we did with alcohol. That's not the problem. The problem is the ownership, the analysis of what the facts are, and the correction. So the greatest glory in living lies not in never falling down, but in rising every time we fall. Nelson Mandela did that. Think of what he did. 27 years in prison, came back to be a leader of a wonderful country. We can do the same within ourselves. Understand carbohydrates are a toxic substance. Obesity is not the cause, it is the result of the problem. Help our kids to understand how their lives work, and we will be successful. We will correct where we've fallen into a diet fat is bad for us trap, and we will rise and cure our society of addictions. Thank you.